Welcome, friends. We are going to have one interesting topic today. That's an essay question on renal stones, urolithiasis. There are 4 essay questions asked in MGR University exam for the past 5 years. From 2018 paper, I have all the papers in my hand. So the questions which are asked recently are, number 1, penile cancer is asked in the essay question. So we have already discussed it. Testicular cancer is asked as an essay. It is also discussed. And the 2 other essay questions are renal cell cancer and another one is renal stones. So we are going to discuss all the essay questions because of the you are nearing your exams. So better we will focus more on the essay questions because clinical topics we have finished most of the topics. So coming to urology from 28th edition, one of the extraordinary content in Bailey. So just basics of urology before going to the essay question. The essay question is actually a classical question. Renal stones, I will discuss it. But before going to that, some of the important investigations and small points from Bailey, which may be asked as a PG entrance MCQ also will be very helpful for you. So ureteric colicky pain is a pain which can radiate from loin to, the pain is seen in the loin, it radiates to the groin or it can radiate to the testicle. So there are 2 methods of pain. The pain can radiate from the loin to the groin or to the testicles. So that there are some nerves which is carrying. What is mean by radiating pain? I hope you know what is the difference of radiating pain and a referred pain. So referred pain is a pain which is found only in a distant site, but not at the original site, not at origin site. For example, a patient having a diaphragmatic irritation will have pain in the shoulder, but not in the diaphragm. But radiating pain is a pain seen at origin and also the pain is seen at a distant site. Very interesting definition. So radiating pain is seen at the origin as well as in the distant site, whereas referred pain is not at the origin site, only at the distant site. Okay, only at the distant site you have pain is known as referred pain. So in ureteric colicky, you have a pain radiating. Means what? There is a pain in the loin and also pain in different sites. In the groin, the pain in the groin is because of some nerve. There is a common nerve innervation that is causing this type of symptoms. So can you tell me the reason for pain which radiates from loin to groin? What nerve carries the pain from loin to groin? It is iliohypogastric nerve. It is because of the nerve which is carrying this pain is iliohypogastric nerve. And testicles is because of genital branch of genitofemoral nerve. So there are 2 nerves which are carrying pain from loin to groin is because of iliohypogastric nerve. Loin to testicles is because of genital branch of genitofemoral nerve. So don't forget, ureteric colic never radiates to chest or back of the leg. These are direct lines from your book. So please don't forget these points. And the important symptom, the most common symptom in urinary topics is dysuria. What is dysuria? Dysuria, Bailey says a very interesting definition. It is a pain while passing micturition, as if you are passing a glass in the urine. The pain will be there during the entire urination. The patients will have burning sensation. It is similar to passing a broken glass through the urethra and the bladder. You have this pain. It is most commonly due to urinary tract infection and rarely due to carcinoma in situ. So most common cause of dysuria is urinary tract infection. So there are many symptoms. I want you to know the clinical symptoms. What is the cause? I'm giving the clinical symptoms. Tell me the cause. Suprapubic pain when the bladder is full and relieved by micturition. There is a pain in the suprapubic region when the bladder is full and the patient feels the pain is relieved on passing urination. What is it? It is a rare disease known as interstitial cystitis. Interstitial cystitis is the condition in which idiopathic inflammatory disorder of middle-aged woman. So this is very important. Please don't forget this is idiopathic inflammatory disorder of middle-aged woman. Sudden testicular pain in a young boy is usually due to, what is the cause of sudden testicular pain? Sudden testicular pain is mostly due to torsion. Okay, so orchitis will have a gradual increase of pain, whereas sudden testicular pain, you should think of torsion of testis as well as torsion of the appendix of Morgagni. It's a small appendage known as Morgagni. Appendix of Morgagni. So these two torsion can cause sudden testicular pain. Dragging sensation. Patient now comes to you with a complaint of dragging sensation, which is more common in the end of the day. As he's working, he's having pain in the end of the day. Is due to what reason? What is the cause of the pain which is due to dragging sensation? Is due to varicocele testis. Okay, varicocele testis is the cause of dragging sensation of pain. Short-term testicular pain. So following which surgery? Some patients after surgery have a short-term testicular pain 10% and chronic testicular pain in 1%. This consent should be obtained before doing one very commonly done surgery known as vasectomy. Before doing a common surgery known as vasectomy, you should get a consent that you may have a short testicular pain or a long-term testicular pain in 1% of the patients. Patients having perineal pain, suprapubic pain, low back pain. See, here is the pain radiating to the legs. Which condition you have? Perineal pain. Please don't forget, it's a classical MCQ topic. Perineal pain, suprapubic pain, and low back pain radiating to the leg is due to prostatitis. Please don't forget, it is due to prostatitis. Prostatitis will cause this. So dysuria, I told you, most common causes urinary tract infection, rare causes carcinoma in situ. So this is a chapter on clinical symptoms in urology. So the other important symptom in urology is LUTS, which is known as lower urinary tract symptoms. So LUTS is a topic very important for PG entrance exams. So lower urinary tract symptoms can be divided into storage lower urinary tract or voiding lower urinary tract. Storage is, it is related to the storage by the bladder, storing of the urine by the bladder. And voiding is, as a patient passes urine, what are the problems which can happen? So when there is a problem in the storage that presents as frequency, night urination, urgency, urinary incontinency, the etiology or neurological disease like neuropathy or overactivity, the storage type of LUTS is most commonly seen in CNS disorders like CVA patients. CVA patients, you can see suddenly they will pass urination because of the increased overactivity of the detrusor muscle. The detrusor muscle is having so much of activity, results in these problems. When there is a difficulty in voiding, when the patient passes urine, is unable to pass urine, there is a hesitation, thin stream, straining, and after passing urine, still some urine is dribbling. So this is very commonly seen, and it is BOO, due to benign prostate hypertrophy or bladder neck strictures. So bladder neck stricture and benign prostate hypertrophy causes bladder outlet obstruction. So this is very important, and the definitions are very excellently explained in Bailey. Nocturia means night time. At least once the patient is waking up in the night. See, for example, a patient lies at 10 o'clock and wakes up at 6 o'clock. If there is a nocturia, the patient is waking up in the night time, it is because of diabetes or some reason. And one of the reasons is storage LUTS. Too often urination is frequency. Strangury is constant sensation to void. So one of the excellent chapter in Bailey and Love, I'll tell you, the entire Bailey and Love, the best chapter is in urology. So excellent contents are there in Bailey. So when you read Bailey urology, you will always love to become a urologist. That much excellent contents are there. So strangury is a constant sensation to void. The patient will feel they want to go to urination very frequently. Again and again, they want to go for urination. That is strangury. And sudden compelling sense to pass urine is urgency. Urge incontinency, there is a sudden compelling sense and he could not control, and urine comes in the room or in the bedroom itself. Okay, that is not even going to the restroom. He is getting an urge incontinency. Stress incontinency, all of you know very commonly, which is following a cough, that is due to weakness of the internal urethral sphincter. They will suddenly go for urination. Stress incontinency. Nocturnal enuresis is night urination in the bed. So hesitancy, difficult to initiate, intermittency, it stops and starts, post-micturition dribbling, involuntary loss after complete urination. So many interesting symptoms are there in urology. So various urination related hematuria, various colored urine. We are going to discuss now colored urine causes. Hematuria, tell me what is the cause of initial hematuria? When the patient is passing urine, they are having hematuria. It is usually due to urethral pathology. Okay, very important. Urethral pathology. Any pathology or a tumor or any lesion in the urethra will have initial hematuria. Throughout, it is bladder and kidney pathology that will be throughout. What is terminal hematuria? Hematuria at the end. Bladder, neck or prostate pathology. Prostate pathology will have hematuria in the end. So please don't forget painless hematuria. Painless hematuria, called as painless terminal hematuria, is a classical case of cancer bladder. Cancer bladder patients, after passing urine, the tumor rubs in the bladder and bleeds. So they have terminal hematuria. So when you have hematuria, visibly you are having chances of 20% chances of cancer. Non-visible hematuria, the risk of cancer is less than 5%. What is this hematospermia? When they are ejaculating, the sperm comes mixed with the blood is also due to prostate pathology. Air coming through the urine. So a colon connected to the bladder by means of a fistula, that is colovesical fistula. So when there is a fistula with a colovesical fistula, the urine will have air coming. So white urine is usually a sperm. Sperm in the urine is nothing to worry. It is normal. Okay. Sperm in the urine or chyle in the urine, all these produces white color. So sperm in the urine is most common, nothing to worry, it produces white urine. Okay, so nothing to worry about sperm in the urine. And other colorful urines, red color urine can also due to hemoglobinuria known as March hematuria. What is March hematuria? This is seen among soldiers. Soldiers walking in the march fast continuously in the heat for a long time, they'll develop hemoglobinuria. That is myoglobinuria or hemoglobinuria, all these will produce red color urine. So can you tell me which drug causes orange color urine? Orange color urine, which drug? It is rifampicin, chemotherapy. Rifampicin and isoniazid, two drugs can cause red orange color urine. Which vegetable causes red urine? The patient will come to you rushing, telling they're passing hematuria after eating beetroot. Brown urine is very common, especially when you give metronidazole to the patients. Patients will come to you with a metronidazole thinking they are having a jaundice. Metronidazole and nitrofurantoin, another important differential diagnosis is jaundice patients will pass brown urine, is nothing but dark yellow urine called as obstructive jaundice. Patients will have brown urine. So therefore, these are all various causes of various colored urine from Bailey and Lowe. And now when you are examining the kidney function, the basic test you should not forget is the surrogate marker for kidney function. How to say this kidney is functioning well? It is very simple test, serum creatinine. But the ideal test is eGFR. So eGFR is the ideal test, but the problem is we cannot estimate the glomerular filtration rate in all the patients. It is not easily available, so we cannot always do eGFR. But optimal method to calculate the urine output is eGFR. You can see it is very clearly given in Bailey and Lowe. eGFR is increasingly reported along with the urea creatinine as it is more informatory of true renal function. So they are saying this eGFR, known as estimated glomerular filtration rate, is becoming more accurate as per Bailey. Bone mets are dated by a simple blood test, serum alkaline phosphatase. So these are the blood tests you should do for a kidney patient. PSA, very important update. This is a very important update in new Bailey, which is changed in this new edition. Previous edition was mentioning one important test. So previous old edition Bailey. This is from old edition Bailey. You can forget it. Serum PSA normal value is less than 4 nanograms per deciliter. This is old Bailey. And when it is more than 10 nanograms per deciliter, it is chances of cancer prostate. Therefore, they used to do screening. They used to do screening for prostate cancer in old age in Western countries. Screening done routinely in those days. Now, there was a trial done in UK, very, very important landmark trial. Okay. So landmark means which is going on for a long period. It's a landmark trial. Protect trial, what does it say? So 27th edition Bailey was saying screening done routinely. 28th edition Bailey says very important update. Protect trial, no need of screening for prostate cancer because it is not so accurate. With the prostate alone, prostate PSA alone, you cannot diagnose the prostate cancers. So no need of screening with the PSA value. is a new update. That trial is known as PROTECT trial. They have found by doing a routine screening, even after 10 years, the number of death is not, major change is not there. So therefore, this is not done. PROTECT trial, no need of screening with the PSA. So total PSA is influenced by drugs. It is changing with various drugs like aspirin, finasteride, furosemide. A recent urinary tract infection returns to normal after 6 weeks. So in recent urinary tract infection returns to normal only after 6 weeks. So therefore, we cannot use this for many patients. So all prostate pathologies like BPH, prostatitis, and even for cancer, all the cases have increased prostate specific antigen level. So it is not so specific, so good. Therefore, PROTECT trial says no need of PSA value. So instead of PSA, they are now using many values like free PSA, complex PSA, free PSA ratio, PSA density, PSA velocity, PSA doubling time. All these are newly used values of PSA now in practice. So very important for final year exam is midstream urine. In a midstream urine, when will you say there are normal, or when will you say it is abnormal? So WBC, please remember, WBC should be 3 to 5 per high power field. Epithelial cells from the kidney or transitional cells should be less than 10 to 15. Very, very dangerous is red blood cell. Microscopically, if you get more than 2 RBC, it is dangerous. So these are all very basic point. RBC less than 2, WBC 3 to 5, epithelial cells 10 to 15 is considered as normal. Can you tell me in which condition you do early morning urine specimen? It is for acid-fast bacillus, and for acid-fast bacillus, now many tests are available, as you all know, along with the urine in the early morning specimen for 3 days. We have to do for diagnosing renal TB. In that, you can also do the important test like CB0. You will be reading in medicine about the tuberculosis new test like CB0, Gene Expert. These are all new tests available which can concentrate the tuberculosis more and can give you more positive result. And voiding the urine and examining for cancer, it is very less. So voiding urine cytology is very, very less sensitive for low-grade tumors. For low-grade tumors, it is less than 15% sensitive. For high-grade tumors, it is around 50% sensitive. So it is not commonly used, but you can do as a screening test. It's a simple screening test, presence of cancer cells in the urine. And you can also look for urine for Kyle giving a fatty food. Fatty food, after giving a fatty food, if you see the urine becomes white in color. The typical white urine is seen. So these are the basic non-invasive investigations so far we have discussed. Now we are coming to the urology invasive investigations. Tell me the images shown here in the picture. So the first image shown here is a flexible cystoscopy. Okay, flexible cystoscopy to see the bladder. This is rigid sigmoidoscopy, cystoscopy. Rigid cystoscopy is used for therapeutic purposes, for doing some procedures like prostate hypertrophy, TO, transurethral resection. You can see the working channels and all available. We can connect it to a monitor, and through the TV, you can see what is happening there inside. Flexible is only for a diagnostic purpose, not for any therapeutic purpose. Only used for diagnostic purposes, not for therapeutic purpose. So this picture below shows very interesting another image. This is, see how thin it is. It is flexible ureteroscope. Okay, ureteroscope. And this is rigid ureteroscope. Ureteroscope is one which can go into the ureter, which can be passed into the ureter, even up to the renal pelvis, we can pass this ureteroscope. So they are used, both flexible, rigid, both are used for removing stones. Both are used as therapeutic only. Both are used as therapeutic purpose. Don't forget this. So can you tell me in a cystoscope, I'm showing you one image. During a cystoscope, I'm showing you one image. You can see, I want you to know what is this red arrow. What is this red arrow? I want you to tell me. So what is this red arrow? What is this? This is a right and left lobe of prostate. That's the prostate lobes. They are the hypertrophied prostate lobe. We are in the urethra. And what is this red arrow? Very important MCQ. This is known as verumentanum. So what is verumentanum? See, this is a bladder, this is the urethra, this is prostate, this is prostatic urethra, this is membranous urethra, and this is verumentanum. What is this verumentanum? That is verumentanum is the distal limit of transection during TURP. This is a distal limit. You should not do, அதாவது TURP பண்ணும்போது இதை தாண்டி வரக்கூடாது. You will remove this prostate, இங்கே நிறுத்திடணும். Don't go beyond the verumentanum. Verumentanum is the distal limit. So distal limit of TURP is at verumentanum. அது தாண்டி you should not do resect because அந்த verumentanum தாண்டின உடனே தான் you have the very important sphincter known as external urethral sphincter injury can happen. So அதை தாண்டி போய் resect பண்ணீங்கன்னா you will injure the external urethral sphincter. So stop at verumentanum. This is a very basic concept you should not forget. So identify the procedure done here. Picture from Bailey and Love. You can see this is a picture of transrectal ultrasound. In the ultrasound, rectum valiya ulla thalli, you can take 12 biopsy samples from the prostate. 12 biopsy samples are taken from the prostate. There's a picture showing you 1, 2, 3, 4, 5, 6, 7, 8, like that. Both sides you can take around 12 biopsies are taken from 6 plus 6 on both sides. So take from right and left prostate lobes, 12 biopsy samples are taken with the help of transrectal ultrasound biopsy. So this is a very important image from 27th edition Bailey image, which is actually not there in 28 now. 27th edition gives a classical illustration of transrectal ultrasound guided biopsy. So transrectal ultrasound la rectum valiya kutti ulla poi prostate edukurom. So enna biopsy edupom? Prostate la pathina you can take posterior prostate nalla biopsy edukalam. Posterior prostate biopsy நல்லா எடுக்கலாம். ஆனா எந்த biopsy எடுக்க முடியாது? Anterior எடுக்க முடியாது. ஏன்னா you cannot pass through the urethra போய் anterior difficult இருக்கும். So transrectal ultrasound guided biopsy disadvantages are anterior difficult to take. ரெண்டாவது disadvantage என்னன்னா you bring the bacteria from the rectum into the prostate. So there is therefore increased risk of infection is present. Increased risk of infection is present. அதனால இப்ப என்ன பண்ணிருக்காங்கன்னா they have modified the biopsy into new update. So latest method of taking biopsy is you go via the perineum. You can take up to 36 biopsy can be taken. Anterior rectal biopsy can be taken. Anterior prostate biopsy can be taken. Okay, anterior prostate la edukalam 336 vare edukalam. It is more better than transrectal ultrasound biopsy. So please remember this is a commonly used method known as transperineal template biopsy of prostate. So transperineal template biopsy of prostate is the latest method of taking biopsy now. So this is given there in Bailey. Please remember this new update of transperineal template biopsy of prostate. That you should not forget. That is the latest method. Now, how is the biopsy taken from the prostate? Nobody is doing transrectal ultrasound. All of us are doing transperineal ultrasound guided biopsy. So I'm giving you 3 images. Please identify the images. These investigations are known as X-ray KUB. The investigation first done investigation for renal or ureteric stone. So stones in vandana nariya vatti we do this X-ray KUB. So because very important, please remember 90% of the renal stones are radio opaque. 90% stones are radio opaque. So always we will do X-ray KUB. X-ray KUB in this picture is showing you a classical image of stone in the lower pole of the kidney. Can you see that's a lower pole stone in the kidney? So this is a lower pole stone. And what is this? This is a picture showing you lower pole stone in kidney. So it is a stone in the lower pole, or it might be even in the upper ureter. You cannot say where it is exactly, but left lower pole is most common site here. And what is this stone? This is a very commonly asked image-based question for PG entrance exams called as Stagon stone. And here is a very interesting image directly from Bailey and Love. You can see there is a stones remaining. Can you note it? Stone is like remaining all along the lower ureter like a stone street known as Steenstrasse. Steenstrasse na stone kallu vechi road போட்ட மாதிரி இருக்கும். Stone street, like a stone forming in a street. It is known as Steenstrasse or stone street. Please don't forget these images of X-ray KUB. But what is the investigation of choice for renal stones? Investigation of choice for renal and ureteric stone. The correct answer is CT KUB. You should go for a CT KUB. It is 100% sensitive. Okay, CT KUB is 100% sensitive to pick up the stones. Can you tell me what is this investigation shown here? This investigation is showing IVP, intravenous pyelogram. Intravenous pyelogram is very important. Please remember, we give a contrast through the veins that is taken by the heart and pumped into the various vessels, and it goes to the artery, and through the artery, it is entering into the kidney. You can see here, it is entering into the kidney, and through the kidney, it is exiting into the ureter to the bladder. So during that time, you can see the Stagon calculus, you can identify where is it in. You can see from the picture, it is in the lower pole of kidney. Stagon is more in the lower pole. So this is an investigation of IVP showing you Stagon stones. So Stagon stones are noted here, but anyhow, it is very important to identify radiolucent stones can be noted. Radiolucent stones can be identified with the help of IVP. Okay, it gives an excellent anatomical image of kidney, ureter, bladder. What is this investigation? This is a very interesting image from Bailey and Love. This is known as micturating. Micturating, also called as voiding. You are going to pass urine. At that time, you are taking the image. Micturating or voiding cystogram. So when you are micturating or voiding the urine, at that time, you are going to examine the bladder. You can see a interesting image here. This is known as thimble bladder. Thimble bladder is a contracted bladder seen in tuberculosis. Chronic TB will have this thimble bladder. So these are the CT scan, non-contrast CT. No need of even giving contrast CT. Please remember, it is non-contrast CT, not even needed CT contrast. So contrast, non-contrast CT helps me to identify the stones in the kidney. These are kidney stones. So you can see the first picture showing you kidney stones, and this second picture shows me the ureteric stones. Can you see the ureteric stone? There's a stone in the ureter. There's another stone in the upper ureter. This is in the mid ureter. And these are stones in the lower ureter. You can see the typical lower ureteric stones. So stones very classically identified with the help of non-contrast CT. And this is a picture showing you contrast enhanced CT. In a contrast enhanced CT, can you see? This is a classical image of right kidney normal. Left kidney is having a mass. That mass is entering into the renal vein. So this is a left side RCC entering into left renal vein. So left side RCC entering into the left renal vein. So this CT scan is having a classification of renal cyst known as Bosniak classification. Renal cysts are classified by Bosniak. So Bosniak classification is a simple classification. ஒன்னுனா ஒரு கிளியர் சிஸ்ட் இருக்கு பாருங்க, கிளியர் சிஸ்ட் இருக்கு, அதுல ஃப்ளூயிட் இருக்கு. டூனா அதுவும் ஒரு கிளியர் சிஸ்ட் தான், தின் செப்டேஷன் உள்ள இருக்கு. ஸோ இவங்க ரெண்டு பேரையும் நீங்க ஒண்ணுமே பண்ண வேண்டாம். தே ஆர் 0% malignant risk. Thin septation, clear cyst, ரெண்டு பேருக்கு எதுவுமே பண்ண வேண்டாம். 2F, F stands for follow up them. 2F stands for follow up. Follow up பண்ண வேண்டிய patient யாரு? They are having multiple septations. Multiple thick septations are seen. So அந்த மாதிரி கேஸ் நம்ம கொஞ்சம் ஃபாலோ பண்ணா நல்லது. ஏன்னா it can be a cancer also. So multiple thick septation needs follow up. அதே சிடி ஸ்கேன் இமேஜ் இங்க இருக்கு பாருங்க, clear cyst. This is a cyst with a thin septation, you can see here. This is a cyst with a multiple septations. சின்ன சின்ன septations உள்ள இருக்கு. So multiple septations will need follow up. So then comes 2, 3. 3 is 50% are malignant. It is having thick septation, thick enhancing septation. அந்த செப்டேஷன் இருக்குல்ல, அது கான்ட்ராஸ்ட்ல பளிச்சுன்னு தெரியும், பிரைட்டா தெரியும். அப்புறம் 4 is cyst containing solid components. So this is 100% malignant. So please don't forget here, 3 stands for angiomyolipoma. Okay, 4 is mostly renal cell cancer. So which will need surgery. So 3 will need biopsy. At least 1, 2 நீங்க ஒன்னும் பண்ண வேண்டாம். 1, 2 just follow, ஒண்ணுமே பண்ண வேண்டாம். Follow up கூட வேண்டாம். 2F needs follow up. 3 needs biopsy. 4 needs surgery. Okay, this is a classical Bosniak classification. Very favorite PG entrance exam question. Please remember this Bosniak classification. So, and another important investigation recently done is multi-parametric MRI. The CT scan is good for kidney, whereas MRI is good for prostate. Okay, prostate is the best investigation. CT கிடையாது, MRI தான். So, அதை வச்சு ஒரு grading இருக்கு, known as Birat's grading மாதிரி Pirat's grading இருக்கு. Prostate imaging reporting and data system is there, right? Ranging from 1 to 5 grades of prostate imaging இருக்கு. So, prostate you have multiple modality of imaging, like for T2 weighted image, you can see the first one is T2 weighted image. So second picture is showing you diffusion weighted image. Third picture is showing you, fourth picture is showing you dynamic contrast enhancement. Third picture is showing you apparent. So whatever it is, you will detail உங்களை கேட்க மாட்டாங்க. But please remember, staging investigation for prostatic cancer is MRI, which is multi-parametric MRI. Okay, so metastasis is diagnosed by a PET mixed with a CT scan. So metastasis of bladder cancer, PET CT is mandatory. So bladder cancer ku enna paakrom, PET CT use பண்றோம். RCC, it is not much, has not been extensively used, so less commonly used. So PET CT is used most commonly for bladder cancer. For RCC, very less commonly it is used. Prostate la வந்து பாத்தீங்கன்னா PET CT ல ஒரு special type use பண்றோம். This is a very important update. Prostate metastasis கண்டுபிடிக்கிறதுக்கு we have a special method in which we have a gallium 68 PET. So gallium 68 radionuclide substance add பண்ணிட்டு, which will target, what is the use of gallium 68? It will target prostate specific membrane antigen. So clean தெரியும், prostate specific membrane antigen நல்லா தெரியும். So we use this, therefore prostate specific membrane antigen is used for detecting prostate cancer. Expected MCQ, what is the investigation of choice to detect prostate mets? Is gallium 68 PET CT, which is specific for prostate specific antigen, gallium 68. So முன்னாடி என்ன பண்ணாங்க, prostateக்கு முன்னாடிலாம் prostateக்கு they used another scan known as bone scan. But என்னன்னா, bone scan will help you to find the mets only when PSA is very high. So prostate specific antigen அதிகமாச்சுனா தான் bone scan. But now recent update is for detecting prostate mets, we use the only investigation gallium 68 PET CT is the latest. Old investigation is bone scan. So now new update from Bailey and Low, 3 radioisotope scans are available. So radioisotope scans like DMSA. So the first one is known as dimercaptosuccinic acid, DMSA. Second one is DTPA. So third one is mercaptoacetylglycine. So இது ரொம்பலாம் நீங்க மகப் பண்ண வேண்டாம். I will tell you simple method, remember. So DMSA is for showing you the SA is, S stands for structure of the kidney. It will give you the structure of the kidney. Structure enna problem? Like a patient having a scar in the kidney. So kidney la or scar vandiruchi, kidney la due to reflex there is a scar, or any lesion in the kidney. So anatomically edavadhu variation, so any variation in the anatomical anomaly of the kidney, so idella vandu I can use with the DMSA scan. DTPA scan appdi kedai. DTPA scan is going to show you P for perfusion. Perfusion another function. It is very important to show the function of the kidney. So எந்த அளவுக்கு kidney function ஆகுதுன்றது காட்டுறது DTPA. DMSA is to study the structure of the kidney. DTPA for perfusion of the kidney. So dimercaptosuccinic acid, diethylene triamine pentaacetate crinogram. So MAC3 scan. What is MAC3 scan? MAC3 scan is a scan, very important scan. It is a recently used scan. Recently, best radioisotope scan is MAC3. So investigation of choice for congenital. It is a congenital disorder known as pelviureteric junction obstruction. The latest answer is MAC3. So congenital pelvic junction obstruction or pediatric disorder இருக்கு. அந்த பேஷண்ட்ஸ்க்கு the best is mercaptoacetyl triacylglycine scan. So old answer for the same is DTPA. Now it is replaced by MAC3. So old answer for congenital pelvic junction obstruction is DTPA scan. Now it is MAC3 scan. Here you can see the picture showing you TMSA scan. I told you structure. You can see the kidney, normal kidney. In this, you can see the horseshoe kidney. Here is the scar in the kidney. Here is a tumor in the kidney. So it will show you clear-cut anatomy of the kidney, DMSA scan. So this is just have an idea. This is MAC3 scan. So MAC3 scan gives ரெண்டு கிட்னிலும் எந்த அளவுக்கு the radionucleotide substance taken and excreted காமிக்குது பாருங்க. ரைட் கிட்னி, லெஃப்ட் கிட்னி. ஸோ ரெண்டும் நல்லா இருக்கு. ஸோ ரெண்டுலையும் they are secreted very well in the kidney. So in the second picture, if you see, the left kidney does not go downwards. Right kidney is going downwards. Now it is excreted in the right kidney. Whereas left kidney remaining in the left kidney, even after giving furosemide, it is remaining in the left kidney. So this means what? This is a patient who is having a outflow obstruction. Outflow obstruction will have the content remaining in the kidney itself. So like that, you can find out whether the function is in the picture. Rendu kidneyum going down because of poor functioning kidney. Okay, dilated, non-obstructed systems. So then another one showing you partially obstructed right renal. In the detail, I want you to know what is this investigation. Because for PG entrance exams, investigation it is MAC3 scan. This is an investigation. See, that is I am requesting you to go through Bailey at least the images. The images are very important because with the help of images, you will get enormous questions in investigations. See, this investigation is very interesting investigation known as uroflowmetry. This is an investigation going to be studied known as uroflowmetry investigation. Here I am going to see the first picture. இதுல male patient urine போவான் இதுக்குள்ள. He will pass urine into this. So this is male patient passing urine into this, and in this female patient will be passing urine into this by sitting method. So male and female will be passing urine into this, and the flow rate is identified with the help of this. What is the normal flow rate? Normal flow rate should be more than 15 ml per second is normal. If it is less than 10 ml per second, it is some bladder outlet obstruction. So urine flow rate எவ்வளவு இருக்குன்னு பார்க்கலாம். இதை வச்சு uroflowmetry வச்சு you can see how much is the urine flow meter. Okay, this is one investigation. இதே டைம்ல we can also connect one sensor. We can put a catheter into the bladder. We can put a catheter like this. Catheter channel can be passed into the bladder, and through that, at that time, you can ask the patient to pass urine. You can find out the voiding pressure. This is known as urodynamics. Voiding pressure can be calculated. So, நீங்க urine போகும்போது pressure எவ்வளவு இருக்குன்னு பாத்தீங்கன்னா, normal pressure of bladder will be less than 60 centimeter water is normal. When you are passing urine and the pressure is more than 80 centimeter water, it is known as what? Less than 60 centimeter water is normal. When it is more than 80 centimeter of water, it is BO. So you can find out with the help of this urodynamic study and uroflowmetry. Urodynamic study, you can find out everything about the bladder. Let me tell you one by one. During urodynamics, a fine catheter or dual lumen catheter is inserted into the urethra and allow the bladder filling and to record intravesical pressure. Involuntary rise of intravesical pressure. Urine pola. Thana pressure யாருக்கு ரைஸ் ஆகும்? In overactive bladder. Diagnosis number 1. Urine போகாம சும்மாவே bladder pressure அதிகமாகுது. Urine போகும்போது bladder pressure அதிகமாச்சுன்னா BO. Okay, an atonic bladder என்னது? No detrusor activity is seen in diabetic neuropathy. சுத்தமா வேலையே செய்யல. There is no pressure increase at all in the bladder. It is third case. So third case, there is no pressure increased. There is another one, fourth scenario, in which known as detrusor and sphincter dyssynergia. அதாவது urine போகிறாரு, there is when coordinated contraction of detrusor muscle with relaxation of external sphincter necessary to permit normal voiding is lost. அதாவது urine போகும்போது detrusor contract ஆகுது, sphincter not relaxing. This is seen in multiple sclerosis. This is seen in multiple sclerosis, dyssynergia. So everything can be detected with the help of urodynamic study. So whatever I have taken in this 40 minutes is an extraordinary content from urology. So it explains everything done by urologists, every investigation done by urologists. No other book gives excellent content like this, which is there in Bailey and Lowe for page number 447 to 1466. Excellent content on urological investigations. Even I have learned a lot of points when reading about this investigations from Bailey and Lowe. So please go through this investigation related topic. So now we are actually going to start the essay question. You are going to write an essay question on renal stones. It is 2018 MGR University essay question. Okay, MGR University essay question is in 2018. It is asked as an essay question from the students who gave me this. Some students sent me the PDF of all the question papers. So since you are not correctly giving me what questions needed, so I just went through all the question papers. So I'm having the list of around 20 essay questions, which we have already discussed some for. So 12 to 14, we have already discussed. So from this, we are going to discuss renal stones. Let us start with renal stones. Who gets renal stones? Very basic question. Renal stones is seen in men most commonly than women. And it is most common in white people than other ethnic people. And in women, there is a bimodal distribution, whereas in men, it is common in 40 to 60 years. So there are some familial diseases which can cause this, like cystinuria, renal tubular acidosis, and hyperoxaluria. These family histories, environmental risk factors. Those who are living in hot areas and steroids, chemotherapy, all these are modifiable risk factors. So there are questions in PG entrance exam, antacids containing magnesium, aluminum, etc. also can cause diarrhea. So like there are, but it is not there in Bailey, so you may not write. So many drugs like chemotherapy agents, steroids, all these things can cause diarrhea. Sorry, cause stones. So now, what is the pathophysiology? What is actually the problem happening? So the problem is when the urine is excreted via the nephrons, there are some factors which stimulate it. There are some factors which decrease it. So what are the stimulating factors? Can you tell me? It is calcium along with oxalate. When calcium and oxalate are coming, they will join together and they will form Randall plaques. Okay, they are called as Randall plaques. Calcium and oxalate will join together to form a Randall plaques. So calcium and oxalate are two important reasons. Decreased by some factors like magnesium, potassium, citrate, Tom Horsfall protein, mucoproteins, pH changes. These are inhibitory factors. Crystal forms are called as Randall plaques, like we call in gallbladder as Missels. Here it is Randall plaques, which will together form stones. So which is a stone formed in acidic urine? Can you tell me which stone is stimulated by acid urine? It is uric acid stones are more commonly seen in acidic urine. Alkaline pH precipitates. Alkaline urine causes which stone? It is phosphate stones. Phosphate type of stones are seen in alkaline urine as it forms uric acid stone. So these are the basic pathophysiology of the stones. Let us discuss about each stones now one by one. So there are some points out of Bailey I will be telling here from Campbell. Just you can note it in this PDF. The most common type of stones is more than 60% of the stones are calcium oxalate stones, and calcium oxalate stones are two types: calcium oxalate monohydrate stones and calcium oxalate dihydrate stones. There are two types of stones available. So calcium oxalate monohydrate stone is a very tough stone to break. It is a hard stone. Okay, it is hard stone. Calcium oxalate dihydrate is a stone which is having an appearance like this. What is it? The stone is having multiple small prickles looking like a mulberry. Mulberry-like appearance. Therefore, mulberry stone causes more hematuria. So hematuria is most common in which type of stone is calcium oxalate stones. So calcium oxalate stones are precipitated by calciuria, urine having more calcium, calcemia, oxaluria, uricosuria. It is which when citrate level is less, it is predisposes this. So please don't forget, citrate is an inhibitory factor. Magnesium, potassium citrate. Magnesium, potassium citrate will decrease the formation of the stones. When citrate level is less, they will form calcium oxalate stones. So calcium oxalate stones are typical mulberry-like appearance. They will cause more hematuria. Calcium phosphate stones are many types. One type of stone known as apatite stone is seen in infection, and bruchite stone is seen in distal renal tubular acidosis. So bruchite and apatite. There is from Campbell Urology, there is a stone known as triple phosphate stone, which is made up of calcium, magnesium, ammonium phosphate together. This is triple phosphate stone, also called as struvite stone, also called as jackstone, also called as Tagon stone. This is a stone which is formed in Proteus infection. As you see, Proteus organism will break the urea into CO2 and ammonium. Therefore, the CO2 will causes alkaline. So alkaline urine causes more of these stones, triple phosphate stone. So triple phosphate stone is a stone which is formed in Tagon type of stones. So remember, just write the essay question based on these stones. Uric acid stone is seen in hyperuricosuriasia. I already told you, when there is more uric acid coming in the urine, it promotes both calcium oxalate as well as uric acid. Two types of stones are seen. And very important is acidic stone stimulates alkaline urine, inhibits uric acid stone. So you all would have seen the urologist commonly prescribing syrup citralca. What is it? It is an alkaline, which makes the urine alkaline. So makes urine alkaline. So this is very useful. Citralca will help in following stones like uric acid stones, in calcium oxalate stones, even in cystine stones it is beneficial. So therefore, majority of the stones, we need the urine to be in alkaline nature. So that is why we give syrup citralca. So what are the other causes of uric acid stone? Those who are taking more of non-vegetarian, they used to call it as they are secreting more of uric acid. So gout, chemotherapy, though it is not mentioned in textbooks, I'm telling more of non-vegetarian having more of uric acid excreted, that will cause uric acid stone. So gout and chemotherapy for myeloproliferative disorders like lymphoma, leukemia, those chemotherapy can cause uric acid stone. So infection, what are the stones formed in infection? Don't forget, apatite stone is an infection stone. Struvite stone, I told you, triple phosphate stone. These stones are due to alkalinization of urine takes place. Therefore, we should never give what? Never give syrup citralca in these patients. If you give syrup citralca, already they are having alkaline urine, you will cause more alkalinity, more problem. So don't give syrup citralca in alkalinized urine. Already patient having alkalinized urine is more dangerous. So we should know what type of stone is there. Therefore, to give this syrup citralca. Cystine stones are very rare stones. Yes, it is worsens in acid pH. It is in acid pH. It is formed by double sulfur bond. The stones are formed by double sulfur bond, which makes it strong to break by ESWL. Very, very difficult to break by extracorporeal shock wave lithotripsy because of the double sulfur bond. It is seen in cystinuria. It is seen in a rare disease known as cystinuria. Patients can develop cystine stones. See, whatever stones I have told you so far, all of them are radiopaque, except which one? Except uric acid stone. Except uric acid, all stones are radiopaque stones in the kidney. So uric acid stone is a radiolucent stone. So now the symptom of the stone is depending upon the location of the stone. If the stone is in the kidney, they will have what pain? If the stone is in the pelviureteric junction stone, what is the symptom? If the stone is in the mid-ureter, what is the symptom? See, whatever I have mentioned is an anatomy MCQ. What are the narrow points of ureter? So ureter is 20 centimeter length. It is having 5 narrow points. One is uretropelvic junction. Second is crossing of iliac artery. Third is crossing of vas deferens. 4 is at the entry of bladder. And 5 is at the ureteric orifice. So these stones will have typical symptoms depending upon the location. If the stone is in the kidney, they will have only back pain. They have only back pain present. Pelviureteric junction stones will have line pain radiating to testicles. I already told you what is the nerve involved. Line pain radiating to testicles is because of genitofemoral nerve. That is the cause of pain to the testicles. Crossing of iliac artery, juxtaposition of vas deferens, and all mimics like appendicitis on the right side. Mimics like appendicitis pain. A stone in the bladder wall or in the VUJ, this is ureteric orifice, is known as vesico-ureteric junction. So vesico-ureteric junction, the stone, if it is getting obstructed in this place, they have pain radiating from loin to groin due to iliohypogastric nerve. It is a iliohypogastric nerve which is carrying the pain from loin to groin. So tell me the cause of pain. If there is a stone in the vesico-ureteric junction, how will be the pain? Loin to groin. In the uretero-pelvic junction, it is from loin to testis. So understand the anatomy of urology. Urology anatomy is the simplest anatomy of all the anatomies. So the points of kidney are kidney, renal pelvis. This is ureter. So the junction is uretero-pelvic junction. Then ureter is 20 centimeter. It is identified by means of peristalsis during surgery, and lower ureter is entering into the bladder, and ureteric orifice is known as vesico-ureteric junction. Most common site of stone obstruction is where? Is VUJ junction. Vesico-ureteric junction is a place most of the time the stone gets obstructed. So along with the back pain, the patients may have fever if there is an associated infection. So what are the complications which can happen? They can develop pyonephrosis. They can develop xanthogranulomatous pyelonephritis. Pyelonephritis. If you are not going to treat a long-term obstruction patients going from hydronephrosis, they will go for loss of kidney function. So loss of renal function. Renal function can be lost, and very important, many patients comes to you with a hematuria. Hematuria is a complication of renal stones. So hematuria is a symptom as well as it is a complication. It is going to bleed. So pyonephrosis, hydronephrosis, xanthogranulomatous pyelonephritis, loss of renal function, hematuria, all these are complications of kidney stones. And ureteric stones, when it is size 3 to 5 mm, don't worry, it will pass out. When a patient comes to you with an intolerable pain of ureteric colic, only diclofenac is enough. Diclofenac is a drug of choice. So usually in practice, I also used to give Buscopan. They are saying no use of Buscopan. They are saying no use of Buscopan. Don't waste giving it. What is Dietl's crisis? Very interesting phenomenon. Dietl's crisis is also a clinical symptom of a patient with a passing stone. This patient, Mr. Ramu, coming to me, is having a small stone in the kidney. Okay, he's having a small stone, 6 mm stone in the kidney. He is now taking a bottle of beer. He's taking a bottle of beer or alcohol. After eating his alcohol, he is going to have an interesting concept. That is, the stone from the kidney now comes and obstructs at the level of ureter. The stone comes out of the kidney and goes and obstructs at ureter. Now what is going to happen? He is now having intolerable pain, severe pain, because the stone got obstructed at the ureter, and he comes to you with a huge mass in the line because of hydronephrosis. Pain plus mass, he comes to hospital. Within few minutes, after you put a diclofenac or something, he passes the stone out. The stone passed out. The stone passed out. What happens now? The stone came out. Immediately he will pass enormous urine. He will pass liter and liter of urine because it is from an obstructed urinary system. That is known as enormous urine passed out. So you have now cured the stone. See, by a bottle of beer, you have cured the stone. In Western countries, many doctors, they advise stone patients to take a lot of beer so that they will come out. That is not done in India. Our people will take too much then. So please remember, Dietl's crisis is the stone in the kidney passes out following an obstruction pain mass. This crisis is known as Dietl's crisis. Okay, don't forget this. So what are the investigations of urology system in ureteric stone means? I already told you, investigation of choices, non-contracity. The only exception is Indinavir stones. So it can, CT scan can detect both radiopaque and radiolucent stones, except Indinavir. Indinavir is a stone seen in HIV patients taking drugs. On drugs, HIV or HBV virus patients, they will be taking antiviral drugs. No, those patients will develop a type of stones which is very difficult to identify. Okay. So this is an image-based question for your exam. This is a multiple staghorn stones. Staghorn stones seen in the image. Don't forget this image. It's a classical staghorn stone in both the kidney. So staghorn stone is a stone which takes a big size stone, takes the shape of the entire kidney like calyces. So you can diagnose what type of stone is there from urinary crystals. This is a pathology question. So though it is not there in Bailey, it is from Robbins pathology. It is not from Bailey, it is Robbins pathology question. You can identify the type of kidney stone by seeing the urinary crystals. What is the shape of this crystal? Can you see this crystal is like an envelope shape. So envelope is calcium oxalate crystal. Okay, envelope shape is calcium oxalate crystal. So dumbbell, I already told you, calcium oxalate monohydrate is a strong stone. Remember, monohydrate is strong stone, which is seen like a dumbbell. Dumbbell, if you take, you will be strong. Remember like that. So dumbbell shaped stones are monohydrate stones. This is uric acid stones, which are in multifaceted appearance, like multiple faces. Multifaceted appearance is uric acid stones. Hexagonal stones, 100 times asked MCQ, 16 stones. Hexagonal type of stones. This is a classical interesting appearance. You can see the stone looks like a coffin lid. Like a coffin means, dead body keeping coffin, that coffin cover. It looks like a coffin lid. It is triple phosphate, also called as struvite stones. Bruchite stone, another stone I told you in distal renal tubular acidosis, no? Those stones are needle-shaped crystals. So these are crystals. By seeing these crystals, I can identify what is the type of stone from the urinary crystals. So many stones, no need to worry, just give them painkiller, and less than 5 mm usually passes out slowly. Slowly, when you drink more water, it will pass out. So 90% of the stones less than 4 mm will pass out. So 50%, 6 to 10 mm will pass. So therefore what? Only 50% of 6 to 10 mm will pass. We can only wait for a few days. We have to intervene if not passed. If not passed in few days. We can wait for few days. If it is not passing in few days, we have to go for removal of the stones or treatment of the stones. So the most interesting update from Bailey and Love this time is medical treatment with an interesting therapy known as medical expulsive therapy. Even I was reading this concept now only when reading Bailey. So very interesting concept. I'm also thinking of trying this in my practice. There is a stone obstructed in the vesico-ureteric junction. There is a stone obstructed in the vesico-ureteric junction. I am going to give one drug known as tamsulosin. This drug is very commonly used alpha blocker for prostate hypertrophy to relax the muscles. So they found out by using this tamsulosin, it relaxes the ureteric muscle and the stone passed out. Very interesting. It is used for distal ureteric stones more than 5 mm. And it is also used along with shockwave lithotripsy to allow the fragments to come out. Please don't forget, medical expulsive therapy with the tamsulosin is new update in Bailey and Love. So this is a very interesting treatment. Size of the stones less than 1.5. I can pass piezoelectric waves. Piezoelectric waves can be passed on the stone like this. It is like a piezoelectric waves are passed and the stones are broken into pieces and they are passed in the urine. But interesting point is before doing this ESWL, I should always do what? I should always put a stent. Otherwise, what will happen? That stone from the kidney which is coming out, the stones which are coming out from the kidney, they can obstruct the entire pathway like this and form a complication known as Steen's Strass. So Steen's Strass is a stone street, which is a complication in which urine could not now flow out. Therefore, to prevent this complication, always do stenting before doing the procedure. Always do stenting. ESWL is preceded by double pigtail stenting. Remember it. Okay. So when will I do surgical? So usually these are minimal invasive medical, ESWL or non-surgical treatment. Surgical treatment is done for people who are not responding to medicine. Kidney is getting bad. Chronic infection like staghorn stones and all, no medical treatment. We have to operate. And high risk occupation like pilots or those who are in sailors, drivers, they can anytime get a sudden obstruction. So better operate for them. And patient wants, we will operate for them. The most commonly done surgery is now RIRS. Please remember the latest update from Bailey. RIRS surgery. What is this RIRS surgery? See, very interesting update. Please don't forget retrograde intrarenal surgery. What is this RIRS? I am going to pass an ureteroscope via the bladder, through the bladder into the ureter. I go into the kidney and stone in the kidney. I can break and take it with the help of laser. There are many energy devices are available now to break and take the stone. This is very useful only for stones less than 2 centimeter and only for lower pole renal stones, and very useful in obesity patients and patients having musculoskeletal deformities. Why these 2 points are given here? Because for obesity and musculoskeletal deformity, very difficult to make the patient lie prone position. Why prone position? Prone position is difficult in PCNL. Next procedure I'm going to discuss. So in bleeding diathesis and all, it is used. In bleeding disorders, we cannot do PCNL. It is a non-bleeding. I'm not going to injure any tissue, no, so it is better. So don't forget, this is an expected TGMA entrance question. When will you do RIRS? Renal stone less than 2 centimeter, lower pole stone, obesity, musculoskeletal anomalies, and even for renal anomalies like horseshoe kidney and pelvic kidney, and for bleeding diathesis, I will do RIRS. But RIRS is recently updated. Many urologists are still in that training. Most commonly done is PCNL. PCNL is nothing but simple like laparoscopy. The patient is made to lie prone position. Made to lie prone position, and this is a kidney. I will go through the back. From the back side, I will enter directly into the kidney by a small hole known as percutaneous nephrolithotomy. And standard PCNL, I use 28 French size hole. Miniature, I will use 22 French size. So I will pass a nephroscope. What you are seeing in this picture is nephroscope is passed inside, and I will reach the kidney and I will break the stone and take it out. Okay, via nephroscope, the stone is taken out. New update in Bailey and Love is prone position is little discomfort for the patient because anesthesia problems are there. Therefore, new update is supine and lateral PCNL are now done for the patients. So how is the PCNL done? In olden days, what is the new update in PCNL means? Supine PCNL and lateral PCNL can be done. So the major drawback of this PCNL is injuries can happen. Injuries can happen as I am entering like this from backside. I can injure the pleura. Pleural injury can happen. I can injure the colon. I can injure the duodenum. So retroperitoneal structures can get injured. Pleural injury, colon injury, duodenal injury. Many small injuries can happen because I'm doing it under C-arm guidance. I don't know what is there underneath sometimes. So sometimes I can injure nearby structure. So PCNL is very commonly done. Indication of PCNL is for stones more than 2 centimeter. See, I told you less than 2 centimeter now done as RIRS. For more than 2 centimeter, it is PCNL. So lower pole renal stones with anatomy that is unfavorable for shockwave lithotripsy, we can use PCNL. Failed shockwave lithotripsy or RIRS. So don't forget, this is the important question for your exam. Staghorn calculus, the treatment of choice is PCNL. PCNL is a treatment of choice for staghorn stones. So when I should not do PCNL? For pregnancy, when there is an infection, bleeding disorder, or patient is on anticoagulation therapy. When the patient is on anticoagulation therapy or bleeding disorders, please understand very dangerous complication which can happen is when I'm trying to enter the kidney, I may injure the renal artery or renal vein, and there can be intraoperatively, I can injure the Intra-op injury of renal vessels can happen. Be careful. Renal vessels can happen. If I injure such renal vessels, if there is already a patient on anticoagulation or bleeding disorders, they will bleed like anything. Otherwise, many times the bleeding might stop. Okay, very important, dangerous complication of PCNL. Okay, don't forget PCNL. So for ureteric stones, very easy method of removing this is, again, retrograde intrarenal surgery can be done. It is known as Dormia basket. Using a Dormia basket, I can remove the stones very comfortably. So this is a picture-based question. What is done here in this picture? You can see a 20 centimeter double J stent is kept inside the ureter. Double J stent is kept inside the ureter, that is DJ stent. This is mandatory before ESWL. So then what is the original open surgery? Once upon a time, when I was going for urology posting, I used to see many cases of this in 2004, 5 and all. During my surgery period, I used to see so many cases of surgery done. The picture shows two methods of operation. If I open the renal pelvis and take the stone out, if there is a stone here, if this is a stone here, if I open the renal pelvis and take, it is known as pyelolithotomy. If I open the kidney itself like this at the level of Brodell's line, anatomy, Brodell's line is a avascular line in the kidney. Many of you would have read anatomy. Brodell's line is an avascular line along the kidney, greater curvature of the kidney, on the greater curvature. அந்த லைன்ல ஒரு இன்ஜெக்ஷன் போட்டு இப்படி போயிட்டு மாங்காய் வெட்டுற மாதிரி, மாங்காய் வெட்டி உள்ள இருந்து கொட்டை எடுக்கிற மாதிரி, we will cut the kidney and take the stone. That is known as nephrolithotomy. They are all no more done. They are all obsolete. So nephrolithotomy, pyelolithotomy எல்லாம் historical. They are no more done because we have new methods of treatment like RIRS, PCNL. All these has replaced these operations. So nobody is doing nephrolithotomy or pyelolithotomy nowadays. So finally, when you're advising them, what should I advise them to prevent recurrent stones means? Advise them 2.5 liters of water per day. Very important. Advise them dietary calcium. Very interesting point here. Even sir, dietary calcium கொடுக்குறீங்க, calcium தான் அதிகமா வந்துச்சுன்னா there is a stone இல்ல. Why should I? Dietary calcium should not be restricted ன்னு போட்டிருக்கீங்க. In fact, I will give supplement calcium. Very interesting point. So reduce intake of animal protein and salt. Sodium chloride salt எடுக்காதீங்க. Protein, animal protein கொஞ்சம் கம்மி பண்ணணும். மட்டன், சிக்கன்லாம் கொஞ்சம் சாப்பிடக்கூடாது. So what is then not restricted means calcium. Why is calcium not restricted? Very interesting physiology. Calcium நீங்க ஓரலா கொடுக்குறீங்களா, அந்த calcium என்ன ஆகும்? ஓரலா கொடுக்குற calcium, very important point. They will be the oral calcium. What I am giving is absorbed by what? Binds in the gut. It is absorbed in the gut. Absorbed by intestines. So it is absorbed into the intestine, or what happens? They are taken, usually absorbed by the intestine, the routine nadakkum because of the vitamin D3 and the phosphate point. But when I give oral calcium, what will happen? When I give oral calcium, it binds with the oxalate in the gut itself. Very important. Gut la irukra oxalate kuda bind aidum. So gut la oxalate இருக்குல்ல, அந்த oxalate கூட bind ஆயிட்டு it will form calcium oxalate in the gut and excreted in the stools. இப்போ நான் calcium கொடுக்கலன்னு வச்சுக்கோங்க. இப்போ நான் calcium கொடுக்கல, அப்ப என்ன ஆகும்? அந்த oxalate, this oxalate in the gut will not go in the stool. It will be absorbed in the blood vessels. Blood vessels குள்ள போய்டும். GAT absorb ஆகி blood vessel போய் எங்க எக்ஸ்கிரீட் ஆகும்? It will go to the kidney. Kidney குள்ள வந்துட்டானா oxalate யாரை பிடிச்சுக்குவான்? He will take up with the calcium which is there in the blood. So oxalate will bind with the calcium and form calcium oxalate stones. அப்படின்ற physiology சொல்றாங்க. So calcium ஓரலா கொடுத்தீங்கன்னா oxalate blood குள்ள போகாம bowel கொண்டு போய்டும் அப்படின்னு சொல்றாங்க. So when you give oxalate, it will prevent it entering. So when you give calcium, it will prevent oxalate entering the blood vessels. This is concept. This is very important, basic concept which is from internet sources, not from Bailey. So point is, oral calcium is beneficial. To prevent recurrent stones, we can give oral calcium. So this is a very important essay question. Please don't forget. So renal stone is an essay question asked in exam. So etiology, you have to write about etiopathogenesis, clinical features, investigations, and management. So 4 heading போட்டினா நீங்க எல்லாத்தையும் எழுதிடலாம். So renal stones பத்தி 4 heading போட்டினா எல்லாமே எழுதிடலாம். So don't forget renal stones, etiopathogenesis, clinical feature, investigation, and management. So please understand this question and revise it. This is enough for writing an essay question. So hope you are. So any doubts you can post now. Yes, Sudarshan is asking when to use non-contrast and contrast. So usually வந்து contrast CT தான் best. Please remember, whenever you want to do test something, contrast CT is best. Non-contrast CT ஒரு 2-3 இடத்துல தான் யூஸ் பண்ணுவோம். First பாத்தீங்கன்னா CT of the brain hemorrhage இல்ல, extradural hemorrhage, intradural hemorrhage எல்லாம் we use it. Okay, so we use it in hemorrhage. Okay, hemorrhage ல யூஸ் பண்ணுவோம். Intradural, extradural hemorrhage we use it, and kidney we can use non-contrast, but most of the time we use contrast CT scan only. So ultrasound lithotripsy, extracorporeal lithotripsy தான் அப்படி சொல்றாங்க. Okay, so please remember, it is not ultrasound guided lithotripsy, it is extracorporeal shockwave lithotripsy தான் SWVL. So ultrasound வச்செல்லாம் உடைக்க முடியாது stone. It is a type of electric waves which is passed on the stone and it is broken. So it can the stone is localized with the help of ultrasound. Stone எங்க இருக்குன்றதை கண்டுபிடிக்கிறது தான் ultrasound யூஸ் பண்ணுவாங்க. இல்லனா fluoroscopy யூஸ் பண்ணி we use the pulse waves is passed on to the stone. It is a mechanical breakage of stone. Okay. Yes. Any more doubts you have? Very less number of students only attending. I don't know whether to take clinical class. Only 38 students are attending the class. And more students attend only, I will also have interest. Most of you are putting direct message, this class, that class, but number of students attending is very less. I think you are all in exam mode or you are already confident in surgery. IVP is intravenous pyelogram. Okay, it is an intravenous pyelogram. We have to give contrast. We have to give contrast and do the testing. So contrast, IVA kuthina agum. IVA kudu contrast heart pogum. Heart will pump the contrast into the aorta. So aorta lande na renal artery kulla pogum. It will go to the renal artery. Renal artery kulla poitu kidney enhance பண்ணிட்டு contrast will excrete in the urine. So that will show you the kidney, ureter, bladder. That is the concept of IV pyelogram. Okay, so IV pyelogram is very commonly done investigation and done by PGs. PGs கொண்டு போய் பண்ணுவாங்க. Okay, so thank you friends, thank you all. So keep enjoying the Pongal. Happy Pongal for all of you. See you in another session soon. Bye.